Waivers are expiring. Hospitals are tightening budgets. The Department of Government Efficiency headlines feel like a slow motion demolition of public systems. Trust in health institutions sits at its lowest point in decades. People are exhausted, not just by cost and burnout, but the sense that nobody is steering the ship. And to top it all off, a few days ago, the acute hospital care at home waiver, this is a COVID era policy that let hospitals bill for Medicare for inpatient level care delivered directly in patients' homes expired after Congress declined to extend it, forcing many of these programs to scale back or even shut down. Moments like this have happened before. And today I want to present a case study in exactly this pattern and what it means to be inevitable in healthcare. So, most of the markets assume that when the acute hospital at home waiver expires, the entire model will collapse. And that belief confused authorization with demand. The waiver allowed hospitals to bill inpatient DRGs for home based episodes. And that was a regulatory artifact, but not in itself a business model. Dispatch Health was the exception here. Instead, they built around things like avoidable utilization, stars defense, and payer ROI. They build through the standard CPT/HCPCS pathways, contracts with the Medicare Advantage and Medicaid managed care, and tracks results in readmission reduction and withhold recovery. So when the waiver expired on September 30th, 2025, hospital at home programs hit pause. Across health policy media, hospital executives, and policy think tanks, you see these consistent themes. All programs stop. Patients have to return to brick and mortar. Compare that to what Dispatch Health's own Pippa Schulman, the chief medical officer, speaking in a Fierce Healthcare interview, said about the waiver. And I'm paraphrasing here, that the waiver only covers a small slice of at home care models. And besides hospital at home, Dispatch Health provides emergency department visits in the home, skilled nursing facility care at home, and hospitalization follow up. And none of these are affected by the waiver. Patients in hospital at home care could potentially be shifted to a different at home care model to avoid relocating them to the hospital. In this same interview, she also did underscore that the fallback is messy, that there's immense operational fallout, and that plans for hospital at home expansion were disrupted by the waiver's lapse. And the company and hospital systems are trying to plan for both growth and interruption scenarios. While Dispatch Health has publicly accepted that the waiver expiration has real friction and disruption, they position their model as relatively insulated and emphatic that many functions continue unaffected. But to make my point here, we see this one dynamic repeating itself. Recognizing the historical pattern can help contextualize the current moment. In the Industrial Revolution, you had steam engines, textile mills, and railroads that all began in gray zones of regulation. In home acute care, today lives in a similar pre law zone where market adoption outpaces regulatory frameworks. The meta lesson here is that industries that prove themselves to be indispensable will force regulators to catch up. The steam engine didn't wait for permission. Early hospice models were dismissed as unbillable, unscalable, too emotional. Only later did payers and policymakers create codes to match what clinicians already proved worked. Dispatch's Health's ROI logic mirrors how hospice proved cost effectiveness long before CMS reimbursement existed. In the early 2000s, Amazon wasn't trying to reinvent cloud computing. Their core problem was that every internal product team had to build its own servers, databases, and storage systems from scratch. They were solving a basic operational problem: speed and cost at scale. And once that system worked for them internally, they opened to the public, and that same architecture that stabilized their own business became the backbone for startups, government agencies, and Fortune 500s. So, Dispatch Health likewise began as an operational efficiency play for health systems and evolved into payer side infrastructure, which is a utility that now underpins stars and withhold performance. And I also want to note here that funded innovation typically seeks discovery of new technologies and new categories. But Amazon, and hopefully for Dispatch Health, shows how these powerful systems start as back end efficiency plays that mature into the default architecture of an industry. So, if you follow along, you see the common pattern emerge where operators who serve a real demand quietly build the replacement system, and regulation eventually recognizes what the market has already decided. Even the best run systems are feeling how fast the perception of a safe bet can change. The acute hospital at home waiver was a smart move when it opened doors that had been closed for decades. But as the waiver winds down, one question now separates resilience from risk. Can our revenue continue if DC pauses? And if that answer is yes, then your model has crossed into inevitability. And if not now, then at some point you're going to have to rebuild your foundation before you are forced to. Here's what I mean by designing for inevitability. Dispatch Health designed around an unavoidable demand curve. Their service lines, ED at home, SNF at home, hospital follow up, address unavoidable friction points in every payer's cost structure, from readmissions to avoidable ED use to post discharge gaps. None of these pressures vanish when a waiver expires. If anything, they intensify. They centered on consistently solving a problem that can't be legislated away. Second is that they built multi rail reimbursement logic. A truly inevitable model isn't single lane. Dispatch Health had multiple revenue rails: Medicare fee for service, hospital at home. That ran on the federal waiver. It was vulnerable, it was cut. Medicare Advantage. Those plans can still contract directly. That gave them durability. Commercial payers and employer contracts, that gives them flexibility. Evaluation and management of transitional care codes, those are always available baseline billing. Their competitors were hospital at home programs who relied on Medicare fee for service reimbursement through the waiver. Dispatch Health already had Medicare Advantage, commercial, and risk bearing plan contracts that used existing codes or subcapitated bundles. When the waiver elapsed, they pivoted load onto the other rails. A third is that they integrated operationally into payer incentives. Dispatch Health's value proposition aligns with those STARS metrics: the total cost of care, the readmission avoidance, and those are all embedded in payer contracts. Those metrics persist regardless of CMS waivers. This means that their relevance to payers is baked into the business math. 50% reduction or 15 to 30% cost drop directly protects STARS and withhold dollars. Plans are financially incentivized to keep that service alive, waiver or not. And fourth is that they treated the waiver like an accelerant. While competitors launched because the federal waiver was created, these models were compliance first. They were nested within inpatient departments or specific DRG carve outs. But Dispatch Health began years before this waiver and never framed its value around regulatory opportunity. Their logic was that people need acute care, whether CMS notices or not. This waiver allowed faster growth and validation, but it wasn't the architectural cornerstone. And this also helped them build a national brand identity around the concept of in home acute care, independent of any single payer or hospital. And that makes them the reference point. Fifth is that they operationalized inevitability through data and logistics. While many of their competitors essentially built hospital extensions like a clinical service tethered to their hospital license, EMR, and workforce, where scaling means more hospitals and not more efficiency. Dispatch Health built a logistics company that's disguised as healthcare. They built the distributed supply chain, the medical teams, vehicles, dispatch tech, centralized command centers. Their model looks more like FedEx meets urgent care than a hospital spinoff. So this gives them geographic and operational independence from the very institutions now struggling with inpatient margins. Lastly, competitors stopped at clinical validation. While many hospital at home programs focus primarily on improving safety, patient satisfaction, and parity with inpatient care, Dispatch Health matched that same safety and quality rigor while also mapping it to payer economics, quantifying readmission avoidance, stars lift, per episode cost savings versus ED benchmarks. Their reporting bridges the clinical credibility with CFO relevance. So, clinical proof is, of course, essential and will earn permission, but financial proof ensures permanence. So let's be honest about the unease running through the field right now. Some of you may be saying, what if this whole thing really falls apart? I've spent years learning this system that might disappear. I'm tired of chasing rules that change every election, and those fears are rational. But the antidote starts with one question: whose need does your model actually serve? Historically, many programs were and still are built to meet a government need, to satisfy a policy window, a grant deliverable, or a compliance metrics. And that's understandable. It keeps the lights on. But it also creates a generation of organizations whose fate now depends on decisions made in rooms they will never sit in. And here's what I mean by that. Dispatch Health example: the clinician teams are deployed to the home within hours. Policy assumes that patients will drive to clinics, navigate portals, wait for authorizations. Human behavior says otherwise. They built for the real human pattern, that's urgency, immobility, and this instinct to call for help and not to schedule it. Post acute and sniff at home services extend care past the discharge moment, otherwise known as the exact gap in time where most programs lose people. So, in doing so, they protect what patients and caregivers actually value, and that's staying home, staying connected, staying out of crisis. Government pilots, on the other hand, measure success in episodes, metrics, and case counts. So, they solved for the family's need for safety and continuity, not the government's need for data. Now, every clinician who walks into a living room instead of a waiting room earns a kind of trust that no app or portal can replicate. And I think I'm biased here because I started my career in healthcare doing home visits in hospice, where I learned what care really looks like outside of the four walls of the hospital. Entering a patient's home adds a kind of context. You notice the small details that tell the story behind the diagnosis: the broken medical equipment, or the meal still sitting on the table, or the dried body fluids on the walls. There were days when I'd drive 2 hours to reach someone, or even one time when I came home with a line of flea bites down my back from sitting on a patient's couch for too long. And those visits taught me being in someone's home, I think, definitely changes the dynamic of care for good. In any case, Dispatch Health found a way to operationalize trust. And I know a lot of models say that and promise that, but they turned what others treat as bedside moments into these quantifiable, repeatable performance metrics. The same day in home visits instead of next day callbacks, satisfaction scores in the high 90s, a consistent drop in readmissions, and a total cost of care, a measurable lift in stars and member retention across payers, where many peers treated policy windows as their foundation. Dispatch Health treated them as a nice to have accelerant and instead built a model that monetized the outcomes that people will always pay for. I think it's worth mentioning now that public sentiment favors continuity and affordability, not ideology. KFF 2024 tracking poll found that 85% of Americans prioritize keeping healthcare affordable even over expanding coverage. CMS experience data shows patients consistently value convenience, affordability, and continuity of care more than political or policy framing. And in recessions, patients cut discretionary spending, but not essential health use. So demand is price sensitive, not ideology sensitive. All of this is to say that trust may be low, but participation remains high. These are signals, and following them feels radical only until it becomes obvious. So, this moment in history isn't just about Doge or policy fatigue or even Dispatch Health. I don't work for them or know anyone there, by the way. No one's paying me to say all of this. But this is the global pivot from authorized security to earned inevitability. When your value is tied to recurring and predictable demand and not regulatory permission, policy change becomes an operational adjustment, not an existential survival event.